Hello everyone. Today we're going to be talking about minimally invasive sinus augmentation. This is a microsurgical procedure. The procedure is going to first involve the removal of tooth number 14. We have significant horizontal bone loss, which is going to result in a minimal amount of bone between the crest and the sinus floor. This is 2 months after extraction and grafting with socket graft. You can see the floor of the sinus. We don't have enough bone for an adequate length dental implant. What we're doing here is we're making our initial incisions on the buccal. I always like to make my vertical incisions one tooth away from the sinus osteotomy so that the osteotomy isn't anywhere near a vertical incision. I'll make my vertical incisions, then sulcular incisions around the buccal, and an incision across the edentulous area to connect all the incisions of the flap. No need to make any lingual incisions at this point in time. We'll do those later when we go to place our dental implant. With this procedure, 99.9% of the time, we place the implant at the same time that we do the sinus augmentation. What I'm using now is a 13K. It's a chisel. I like to do a sharp dissection of the attached gingiva off the alveolar bone. This is less traumatic. Allows us to elevate the tissue without tearing it, like you would have with a blunt dissection with a periosteal elevator. However, once I've completed the elevation of the keratinized tissue with the chisel, then I'll come back in to complete the elevation of the flap along the periosteum with what's called a molt instrument. It's basically a large spoon. It is sharp though, so it allows us to do a sharp, clean dissection of the periosteum off the lateral wall of the maxillary bone in this area. Now, because we had a lot of horizontal bone loss, some lowering of the floor of the sinus, we're going to be fairly high with our elevation today. You can look at most of your sinus lifts where you have the sinus within 3 or 4 millimeters of a normal crest height. You need to lay a very minimal flap to get to the floor of the sinus, and that's what we've done here. We've just measured off the radiograph to find out how high the sinus floor is. You go about 1 millimeter or 2 above the floor of the sinus, and you make your initial osteotomy with a high-speed handpiece and a normal number 8 or number 10 round burr, but you stop before you get to the membrane with this burr. A normal burr will actually peel off bits of bone, and once you get close to the membrane, you don't want to peel off any of the bone because it can tear the membrane. Once we can see the dark sinus, but we're still in bone, we're going to enter with this burr here. It's a number 8 or a number 10 multi-fluted round burr in the high-speed handpiece. This allows us to do our fine-tuning of our osteotomy, smooth out the edges, and also it actually removes bone in a very minimal manner so it won't catch or tear any of the bone away. And that allows us to gently remove bone over the sinus membrane. And also the burnishing effect of this multi-fluted burr actually stops bleeding. As you can see here, bleeding is very minimal. Here we've exposed the membrane, and now we're going to start our dissection of the membrane. We begin with a microsurgical kit we've developed here. The actual initial instruments are paddles in shape. They're 1 millimeter in diameter, but you need a paddle shape once you're getting this fine of an instrument, because a ball instrument in this small diameter will actually puncture the membrane. So we take the paddle, we press gently against the membrane, and we slip the paddle between the membrane and the internal wall of the maxilla. So always keep the paddle in contact with the bone in the internal aspect of the sinus. And this instrument is designed to only dissect 3 millimeters in circumference around the osteotomy. It actually has an angle that allows you to stop at 3 millimeters. Now we're going to start the next phase of our dissection with a mini ball. The mini ball is about 3/4 of a millimeter in diameter. You're just going to go in with this mini ball and increase your dissection around the osteotomy. You want to sweep back and forth from mesial to the floor of the sinus, to the distal, to dissect maybe approximately 6 millimeters around the mesial distal and floor of the osteotomy. You want to find the floor of the sinus and just begin your dissection there. Now we're going to move on to a larger ball. This is a ball burnisher. It's a medium and a large ball. We start with the small one and we go in. What we're doing now is we're just keeping the ball on bone and we're sweeping the ball back and forth along the floor of the sinus. You want to sweep back and forth until you reach the medial wall of the sinus. Also, you want to use this instrument if there's roots in the area. You may want to dissect the membrane up the root, or if there is a septum, you'll want to try to dissect the membrane over the septum. But usually it's adjacent roots that you need to dissect the membrane off of. But the goal of this dissection is just to dissect the membrane off the floor of the sinus over to the medial wall. That way, when you go in with your graft material, the graft material initially fills the floor of the sinus, and then once that pocket is filled, the hydraulic pressure then pushes the sinus membrane in a vertical or cephalic direction, elevating the membrane as far as you want to elevate it. Here we have the dissection complete. You can see that the membrane is still intact. It's a very simple thing to do. We'll talk more about if you do happen to perforate the membrane. But with the dissection intact, now we go to our graft. You simply insert the tip. You can see the tip is approximately 3 millimeters in diameter, and it inserts into the osteotomy nicely. You put the tip in, you direct it to the floor of the sinus, and you inject the first syringe of the material, which is 2 cc's. You can see we're injecting here, and we're going to go in and take a radiograph. Now you can see that the material fills the majority of the floor of the sinus, except we do have a void in the mesial area of the sinus. But we do have graft material above the area where we're going to be placing our implant. So rather than going back in with an instrument through the lateral osteotomy, we're just going to prepare our osteotomy for the implant. We're always looking at the bone samples looking at the bone that we regenerate, and here you can see we have a trephine that was the first instrument that we used to create our implant osteotomy. Now that we went in with a large ball through the implant osteotomy to dissect that periosteum off a little more, and then we went in with more graft material in the mesial aspect to complete our grafting of the sinus through the implant osteotomy. Now, of course, we're just increasing the diameter of our osteotomy. When you get to the final burr, what you want to do is you want to go all the way to the length of the implant, because at this point in time the graft material is beginning to set up and you don't want to push the graft material off the floor of the sinus, and so you just screw your implant into the depth. What I've done here, I've had some excess graft material and I just grafted over the buccal osteotomy to make sure I've got bone graft over the buccal entrance to the lateral wall of the sinus. And now you can see that we have a very nicely filled and grafted floor of the maxillary sinus. The entire floor is filled with graft material. The implant is in place. And this is 3 months later. You can see that the entire floor of the sinus is now regenerated bone. This bone has a much finer trabecular pattern. It is more denser. Over time, the density will increase. And the success rate of this procedure is very high because the implant will integrate to this new bone into the sinus. At this point in time, we're going to send the patient off for restoration. The restoration, because there was a lot of horizontal bone loss, the restoration is rather long. However, it's very hygienic. The patient's taking good care of it. It's not an aesthetic problem because it's in the posterior with a low lip line, and as you saw, that mustache that he wears. But the implant is healthy and all the teeth are doing very well. One of the possible complications with this surgery is perforating the membrane. You can see this membrane is perforated. However, what I do when I'm doing the surgery, if I have a perforation like this, I just ignore it, continue my dissection, continue my grafting, and I have never had that complication affect the result of the surgery. One thing you need to know is with this graft material, sinus infection is almost impossible. Almost all sinus infections are a result of porous granules like allografts, xenografts, autografts, and with this graft material, sinus infection is nearly impossible. You can see that this is the area that we had that sinus perforation. We simply dissected the membrane like usual, injected our graft material. You can see there's a pilot drill going into the graft material at this point. And now you can see the implant is restored. The inferior portion of the sinus is completely filled with bone. The implant is in excellent condition. This will give you an excellent result. So if you have a perforation of the membrane, I don't worry about it. I just continue working and complete the surgical procedure. Now, there is a situation here where you have very minimal bone. It complicates the surgery greatly, but in addition to complicating this surgery, I was going to put a number of implants into this sinus at the same time I did the augmentation. But here, the membrane tore, and it was so friable I never saw it again. But I just made sure that I had the membrane off the bone, and I grafted it, placed the implants at the same time, and this is approximately a couple years later. The implants are functioning perfectly well. We have good bone around all of the implants, even though we started with about 1 millimeter of bone and placed the implants at the same time as the graft. Thank you very much for listening. Please give us a call for further information.